Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of this show, I'm going to continue to talk about autoimmune diseases. When I left off last week, I was talking about autoimmune white cell diseases, etc. And this segment, I want to continue to talk about it. I just want to continue the treatment of low white blood cell, etc. Before I do so, however, I want to introduce to my faithful, loyal audience my granddaughter, Melissa. Hi,
Hi.
Melissa. Welcome to the show.
Thanks for having
I
me.
just wanted to spend a few minutes chit-chatting with my granddaughter who was visiting me. I'm so proud to have her here. She is, of course, a highly professional, highly educated young lady who is a professional photographer. And she, of course, going to spend the day with me in White Plain, and I'm very, very happy to have her here. All right, Jessica. Melissa. How we doing?
We're
What's
good.
happening?
We're good. It's a little cold, a lot colder than the Bahamas.
of, of course, the Bahamas is a nice but warm place. Yeah.
Yes.
So you're gonna spend a few days in New York doing some photography.
Yes.
uh
I'll
What are
be.
the general plan that you have?
I'm going to have some meetings, get to know the city, get to know some of the people,
hmm
and just kind of relax a little bit, if
Okay.
at all that's possible to do in the city.
Yeah, New York City is a fantastic city. There's so much to do, so much to do. I hope you get a chance to go around and see some of the fantastic things that they have in New York City. Make sure you take a little walk around Times Square. That's really something memorable, something you will always remember.
Definitely.
And you have some professional project coming up as well, right?
Yes, I have a solo show back in the Bahamas,
Uh-huh.
at the Central Bank of the Bahamas. So I'm currently finishing that up so that
Uh-huh.
I can do it on July 4th,
Uh-huh.
actually.
I see. That's
Yeah,
fantastic. Yeah,
yeah.
yeah. Well, again, it is really an honor and a privilege to have a chance to spend some time with you, and I'm so happy and proud that you're doing well and you come to spend some time with me. Thank you so much for stopping by.
Thanks,
I will
Grandpa.
love you always.
Love you too.
Take care. All right. All right. So now we're going to continue talking about the low white blood cell count, as I mentioned, which is more common in certain ethnic groups. So I went through that. I'm not going to repeat that again. However, when I left off last week, I was talking about the need to treat more aggressively people who have leukopenia who also happen to have an infection. The leukopenia itself predisposes them to more frequent infection. When they do have one, however, one has to be more aggressive in treating it with antibiotic, etc. I mentioned the different type of antibiotics that are being used, but in addition to that, I want you to know that we have certain medications such as white blood cell stimulators, such as Neupogen, 400 micrograms sub-Q. We can give that daily or 3 times a week, depending how low the patient white blood cell count is and how infected the patient is, so that we could raise the white blood cells count via migration from the bone marrow so as to enable the patient to fight the infection better. So that's Neupogen and other medications like it. In addition to that, however, we have to be very careful to go about the basis of it. If the white blood cell count is low because of an autoimmune disease, such as rheumatoid arthritis and or sarcoidosis, for instance, or systemic sclerosis, etc. Then if that has been diagnosed and we feel that's the basis of the low white blood cell, then of course we have to treat that disease itself. And sometimes this disease comes in twos, something called overlap syndrome. Then we have them to treat. There are 3 major medications around in the world today to treat those autoimmune diseases, namely steroid. And then if the steroid is all that's available to the area where the people are located, and then the steroid is the cheapest thing around based on the patient height and weight, then one will give the patient either a steroid intravenously or by mouth to try to treat the autoimmune disease itself. And then once the autoimmune disease itself is brought under control, that will also increase the white blood cell count as well. Now, the next medication available is for called something in a medication called Rituxan. Rituxan was not originally created to treat autoimmune diseases. However, it was found to be extremely effective. It is expensive, 750 milligram weekly, until the patient is brought under control. And then it is an anti CD20 lymphocyte type medication. So it will prevent the antigen antibody complex from developing. And then you would, of course, resolve the problem, or be it rheumatoid arthritis, as I stated, be it overlap syndrome, meaning several of the diseases in combination. The rituxan will bring this under control. You monitor it depending what it is, if it's polymyositis or systemic sclerosis, like I stated. Then, of course, you measure the set rate, and you measure as the disease is brought under control, the level of the set rate will decrease accordingly. If it is, let's say, rheumatoid arthritis, well, you do the rheumatoid factor. As the disease is being brought under control, the rheumatoid factor level will go down accordingly, and so on and so forth. If it is, let's say, hemolytic anemia, well, if it's hemolytic anemia, then of course the reticulocyte count level will go down accordingly as the red blood cell, total red blood cell or white blood cell in this case, go down, because it could be just white blood cell in combination with red blood cell. It's not always that hemolytic anemia comes by itself. Maybe it's only hemolytic anemia as part of an overlap syndrome. That's the reason what I mentioned, the reticulocyte count. And of course, if it is, let's say, polymyositis or polymyopathy, then you will monitor the total CK, total CPK, in addition to the set rate. Because the set rate will go down, the total CPK will go down. That is an indication that the rituxan is working to bring those levels down by blocking the inflammatory process, which is the result of the autoimmune disease as well. Let's say, for instance, the patient white blood cell is by itself low by itself, then you use the Neupogen alone. If, let's say, the patient is also the white blood cell is part of an autoimmune phenomena, then you could use IV IgG. You could use IV IgG once a month, 400 milligram per kilogram of body weight, etc. Depending on the size of the patient, you could use that once a month. That will resolve bring under control the autoimmune disease, and so doing you will also raise the white blood cell count. You have to understand that. But you got to be careful not to be fooled, because I mentioned steroid. You have to be careful, because steroid itself, having nothing to do with whether the patient had autoimmune disease or not, or is responding to the treatment or not, steroid itself can, via two separate mechanisms, raise someone's white blood cell count. Whether the white blood cell count was low or not, whether it was normal, it can go up, because by two processes. Number one, the process of migration, namely steroid. You have to remember, I mentioned that several weeks ago. Steroid can cause leukemia reaction by causing migration of white blood cell from the bone marrow into the circulation. So that's very important to remember. Steroid can cause migration of white blood cell from the bone marrow into the circulation. So you have to factor that in if it is steroid that you're using to treat the patient. Sometimes these medications are used in combination. You have to know all this stuff so that you could factor all that things. You don't falsely think that something is getting better when in fact it really is not getting better. It is the effect of the steroid, which could be transient. Again, this is clinical medicine. You have to have enough knowledge, enough experience to know how to deal with this situation. So those are the ways in which we treat low white blood cell count, in addition to providing the patient with antibiotic if they are infected. That is all I want to say about white blood cell. I spent 3.5 shows now talking about it. The next autoimmune cell, we have white cell, red cell, is platelet. There are several autoimmune platelet abnormalities that you need to know about, and they can be very serious. The most common ones are ITP, TTP. Okay, those I have the list here. Okay, these are they can be by themselves. They may not be associated with autoimmune disease. You have to remember that. But ITP is an autoimmune disease. TTP is an autoimmune disease. And you could also have Hashimoto's thyroiditis, can be associated with thrombocytopenia, which is low platelet. Celiac disease can be associated with low platelet. That's an autoimmune disease. Evans syndrome. Evans syndrome is an autoimmune disease that can also be associated with low platelet. Very crucial. Now, you have to remember something. There are many, many other reasons why somebody's platelet may be low. Very, very, very serious thing to remember. Let me give you an example. The most common cause of low platelet in the hospital setting, that is somebody who is a patient in the hospital, happens to be infection. Let me repeat that. The most common cause of low platelet in the hospital setting happens to be infection. It may be the low platelet by itself, or it may be the low platelet associated with DIC. So you have to understand that when somebody is in the hospital, they're being treated for whatever they're being treated for, and suddenly out of the blue, the platelet counts start dropping. You got to remember several things. Is the patient getting heparin? Yes or no? If the patient is not getting heparin, and suddenly the platelets start going down, you probably have to think of the possibility the patient may have an infection. Whether the infection is obvious to you or not, it's a different story. It may very well be associated with DIC. There are ways of differentiating the two. It's not that difficult. You could do all these expensive tests, but if you have enough experience, you go into the laboratory, you look at the blood smear. If the platelet count is low and the red blood cell count are completely normal, there's no breakdown of the red blood cell, nothing like that, then you begin to think of an infection. However, if the red platelet count is low, and all of a sudden you look at the red blood cell at the same time, you see a lot of breakage in the red blood cells, then you start thinking about DIC. Okay, these are things that you have to be able to know these things, but most likely this is in the privy of the hematologist to know these things. So, why did I mention heparin? It is frequent for individuals to be in the hospital to be treated for heparin because of a clot that has been diagnosed, or to be treated with heparin prophylactically to prevent the development of a clot, DVT, etc., and or the patient just getting heparin flushing in an IV line to prevent the line from clotting. That little bit of heparin that's being given in the IV line to prevent clotting in the IV lines is sufficient to cause a condition called heparin-induced thrombocytopenia, which could be very serious and very deadly. This is a diagnosis that cannot be missed. You cannot, let me repeat that, you cannot miss the diagnosis of heparin-induced thrombocytopenia. Because if you do, the patient is at high risk of getting major, major complications. Heparin is an excellent medication. It's being used all the time, either as treatment or as prophylaxis. Treatment for a clot, as I just mentioned, and or to prevent a clot. But when you are doing that, you are monitoring to see if the patient is not bleeding from the heparin by doing a complete blood count. Okay? Here's the key. While you're doing your complete blood count, you look at the baseline platelet count that you did before you started the patient on the heparin. If the platelet count has decreased by 50% of what it was when you started the patient, even though it may still be within the normal range, that's a red flag. You should stop the heparin immediately. Because by tomorrow, it's going to be worse. And the day after, it's going to be catastrophic. Let me repeat that. You have somebody on heparin, legitimately, either for treatment of something that the patient has, such as a clot or whatever, or as prophylaxis. People get heparin all the time. They're having cardiac surgery. They have heparin and so on and so forth. The, the number is, if the platelet count drops by 50% of what it was before you started the heparin, that's a red flag. The heparin must be stopped quickly and fast. And then you must quickly begin an evaluation for heparin-induced thrombocytopenia, which is an autoimmune phenomenon, whereby the patient heretofore could tolerate heparin fine. Now he or she has just developed an autoimmune disease secondary because of the platelet, okay? I mean because of the heparin. That is catastrophic if it's not recognized right away. The list of things that can cause someone to have low platelet is really, really quite long. I mean, I just mentioned antiphospholipid syndrome, lupus. I mentioned Hashimoto's, which is a thyroid disease. The list is very long. Suffice it to say, you have got to keep these things in mind when you see somebody with low platelet. ITP is very common, extremely common. This is not a new disease. ITP has been around for a very long time, but suddenly somebody, for a reason that's not clear, develop low platelet. And you must investigate it. Again, the way you investigate it, you do the blood count. As soon as you see the platelet is low, you find out why. Why is the platelet low? What's the PT look like? What's the PTT look like? What the set rate looks like? What the ANA looks like? You palpate the patient's abdomen. Is the spleen enlarged or not? Is the liver enlarged? Is the patient cirrhotic? Because all these things, cirrhosis can cause portal hypertension, which can secondary hypersplenism, which then can lead to pancytopenia, and which can include low platelet. Super, super crucial thing that you have to know. And what you also have to know, when the time comes for me to talk about treatment, I will tell you how to be more aggressive or not to be more aggressive depending on the level of the platelet. If the platelet is low, that is you've just diagnosed thrombocytopenia, then you are required to evaluate that. And the way you evaluate it, you're looking for autoimmune diseases. Again, you do your exam, look at the skin, is there a rash, is there alopecia, if the patient have aches and pain, you're looking for all the associated problems. Examine the thyroid gland, examine the eye. The patient may have Graves' disease. Graves' disease of the eye is an autoimmune disease. So the way the eyes look, the way the patient is staring at you, the way the eyelid look, those are crucial to make sure that this patient doesn't have Graves' disease. You examine the thyroid gland. Is it enlarged? Hashimoto's thyroiditis, and so on and so forth. On the top of thyroid problem that could be autoimmune in nature. And you go on down to the abdomen, I just mentioned, palpate the spleen, so on and so forth. After you've done all this stuff, remember, from the toenail all the way to the fingernail, those are crucial things that you have to look at. Then, after you do all your exam, was it just the low platelet by itself when you do a complete blood count, and or was other blood cell were abnormal as well? Was the white cell low? Was the red cell low? Or was it just the platelet that was low? Then you do a complete liver function test. Is the kidney profile abnormal or normal? Is the liver profile normal or abnormal? Because abnormal liver profile could tell you the patient is cirrhotic. And the cirrhosis, of course, is very well known to be associated with low platelet. So it may not be autoimmune at all. It may still be autoimmune and yet have abnormal liver function test. Then you have to figure out what's going on. What is the LDH? How does LDH get into this picture? Well, LDH get into the picture because there are several conditions that can cause one's LDH to become elevated because certain cells in the body grow via anaerobic pathway, and those cells can be malignant in nature. So it's not at all unusual for someone to have a lymphoproliferative disease that present with low platelet count. But if you're smart enough, in the process of evaluating that, you did do an LDH, your LDH is high, aha. Why is the LDH elevated? Is the patient hemolyzing? Yeah, hemolysis can cause elevated LDH. Is the patient liver function abnormal? Or is the LDH elevated part of a cirrhotic liver disease phenomena? Yes or no? And if that the answer is no, then you still have plenty of work to do. Because you can't just take elevated LDH and push it aside. You cannot do that. Because you just been given a piece of gold on a plate, but you have to know to recognize it is in fact gold. Why? Because it's LDH. You don't just put it aside and say, well, the LDH is high. Of course not. LDH is crucial. In fact, not only it is crucial to help you to diagnose lymphoproliferative diseases, it's crucial when you're treating the lymphoproliferative diseases because the LDH, you could use that as a monitor. The better the disease is getting, the lower the LDH is. Okay? And so on and so forth. If the patient has a autoimmune disease that is associated with not only low platelet but also low red blood cell count, your LDH is still crucial because the patient may be hemolyzing. And the two most important tests that one uses to evaluate hemolysis is the reticulocyte count, the red blood cell count, and the third one, of course, is the LDH. Yeah, you can't be hemolyzing and don't have elevated LDH. You can't have an lymphoproliferative disease and don't have LDH. Elevated LDH and the lymphoproliferative disease can come at the same time. Yeah, yeah. Your SED rate is, you do a SED rate, all these abnormalities are there, and yet your SED rate comes back normal. Something is fishy here. Why is the SED rate normal? It's normal because you did it during cold temperature. It was sitting in the cold area where you do it. However, if you take that same tube that you did the SED rate, move it over to an incubator at 37 plus degrees, all of a sudden you check it an hour later, it's 80. Well, hallelujah, you just diagnosed cold agglutinin diseases, which are very highly associated with lymphoma of different types. Oh, and the low platelet may be the presenting thing. How about that? So you have got to understand these things are out there. Yes, the knowledge is out there. If you don't know this thing, please ask someone who knows this stuff to help you to evaluate the patient. Don't take it and put it aside, say, well, the SED rate is normal or low. That means the patient cannot have inflammatory disease. No, cannot have autoimmune disease. You're wrong. Okay? So clinical medicine, my friend, is an art form. It's an art form based on science, but you have to know the science so that you can incorporate the science together with the art form to practice high power clinical 21st century medicine. It is crucial that you know this stuff. Okay, now, getting back to platelet by itself, you could differentiate using a smear the TTP to the ITP under the microscope if you know what you are talking about. These things are crucial. You're talking about somebody's life is at is I mean, you're talking about low platelet. This is serious business because low platelet can cause you to bleed spontaneously in the brain or the vital organ spontaneously. So this is nothing that you have time to wait for. You have to know this stuff, and you better know it or find somebody who knows it. So low platelets as part of an autoimmune disease is extremely common, more common than you can possibly imagine. And I mentioned before that somebody may have low platelet because of heparin. If that's what's going on, you dare not, absolutely dare not ever touch this patient again for the rest of life with anything having to do with heparin. If you do that, then you just created a major catastrophe. But how are you going to know that if you don't even know such a thing as heparin-induced thrombocytopenia exists? Because the patient comes in, you evaluate the patient, you're doing what you're supposed to be doing, and the patient, out of the blue, the platelet comes down to less than 50,000 than it was before. You didn't pay attention to it. The next thing you know, the patient is given very, you know, benignly, the patient is line is being used with heparin, tiny little bit of heparin in a small 1 cc needle to try to keep the line from clotting. Little did you know that little bit of heparin can cause the patient in his or her life to an acute phenomena by that little benign thing. There is no such thing as little benign things. The little benign things are sometimes the most crucial things. So this stuff is serious business. And when I begin to go over the different ways, different things that are associated with ITP versus TTP versus DIC and so on and so forth, you'll get to understand more fully how crucial these things are and how to detect them, how to evaluate them, and how to treat them appropriately and properly for the benefit of the patient. Listen, I'm going to stop here. Next week, I'll continue to talk about thrombocytopenia. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.